Shaheen. I have a PhD degree in epidemiology and population health, and I am an assistant prof at An-Najah National University. It's a great honor for me to be with you today at the Lancet Palestinian Health Alliance conference. I'd like to thank the organizing committee for giving me this chance. Today, I will talk to you about barrier to disclose domestic violence in health services, a qualitative interview-based study. So, why it's very important to investigate violence against women in worldwide as well as in Palestinian territory. According to a report that was published by the World Health Organization on 2013, 1 in 3 women were exposed to violence worldwide. The situation in Palestine is not different, where, according to a result of a report that was published by the Palestinian Central Bureau of Statistics on 2019, 27% of ever married women had been exposed to at least one type of violence. In Palestine, we do have a national referral system. The last actor to join this referral system was the Ministry of Health on 2016. This study is part of a large study called HERA that stands for Healthcare Response to Abuse and Violence. The aim of the current study is to qualitatively explore barriers to disclose VAW in primary healthcare clinics in Palestine. For this, we interviewed 20 women who aged 18 and more. Basically, what happened, we approached 2 legal centers where these women are receiving services. The social worker in each of these centers was approached and called the women describing our study, and women who agreed to be part of our study were invited to be interviewed in each of these centers at the presence of the social worker. The interviews were conducted in Arabic and were audio recorded. Data were thematically analyzed. I'll go with you now to our results. Barriers to disclose violence by women were clustered around these 3 levels: individual level, healthcare services level, as well as societal level. The followings were the barriers at the individual level. Women were fearing if they disclose violence, their perpetrator, in most cases was husband, will know, and this will intense the violence on them. So this was one of the barriers for them to decline in disclosing violence. And in some cases, women decline to disclose violence because they don't want to hurt their husband. They were scared that if they disclose violence, the husband will be arrested. Some of the women felt shame at recalling the experience and retelling it to others. They believe that they are human, they aren't supposed to be exposed to this type of violence, and hence this may decline them from disclosing violence. And some of the women feel like that they will be psychologically distressed if to recall the experience again and tell it to healthcare providers acknowledging their status. Hence, this prohibited them from disclosing violence. The current quote that I'm presenting here is reflecting on shame and embarrassment, where the women went on saying, I felt like I would be blamed for it And people might say, look, she let out secrets between her and husband. Why would she say that? So that would make me shy, embarrassed to talk about it. The followings were barriers at healthcare services level. Women felt that the clinics are overcrowded and there is lack of privacy, and they will be overheard by other patients inside the clinic. So this prohibited them from disclosing violence. And in most cases, healthcare providers usually are living in the same residency as the women. Hence, this created a lack of trust between the women and the healthcare providers, fearing for their confidentiality and for the data for the information that they will disclose for these healthcare providers. Some of the women noted that healthcare providers usually focus at physical health and they don't pay attention to the psychological consequences of violence. And this limited their chance from disclosing violence, while other women noted that healthcare providers are overwhelmed with clients, and when they know this, they just only don't disclose violence to them. And the current accord is reflecting on this particular barrier, where the women went on saying, yes, I had the potential to, but I didn't feel like the doctor would listen to me if I did, because there were a lot of people waiting for a turn. And other than that, she works fast. She doesn't ask about the person's state. It was just an exam for the fetus, and that's it. Work is done. The followings were barrier at the societal level. So, like, women felt that if they disclose violence and the community will know about their disclosure, this will make them abandoned by the society, and this prohibited them from disclosing violence. Some of the women felt reflected that if they get divorced because of disclosing violence to healthcare providers, this will make them, the community will stigmatize them as divorced women. Most of these women grow up in an environment where they used to listen to the fact that what happens between them and husband is normal in terms of violence. Your mom was violated, your grandma was violated. That's normal to be violated by your husband. The sort of life. So for them, this is normal. Why to talk about it to healthcare providers since it's normal? And most of the women in our study were like fully financially dependent on their perpetrator, which is in most cases the husband. So if they to go back to their family home, the family will reject the children of the perpetrator. And this may put the women in fear of losing their children. And here I'm presenting on this particular barrier where the woman went on saying, because my family, if I divorced, don't want me to keep his children, and I don't want to lose my daughter. If I lose the children, I will suffer. Before going on into implication of our results, I'd like to take you into the strengths of this study. This is the first study to investigate barriers to disclose violence by Palestinian women who are exposed to domestic violence in the West Bank. And this is very important. It's the women voices. Our results reflect on collective experience rather than individual experience. However, there are limitations for our study that are our result might not reflect all the barriers that are experienced by women, since our interviews were limited to 2 legal centers. It's as well because the participation in the study was at voluntary basis. So this might women who are like interviewed may possibly they are the ones who feel free and comfortable to talk about the topic, while those who are severely violated and scared were not reflected. Their barriers and their views were not reflected in our study. We hope for the results of our study to be used in training the healthcare providers on how to ask sensitively about vow in private places rather than in overcrowded places, and it's how to reassure survivors about their confidentiality and how to pay attention to other type of violence rather than just only focusing at physical violence. We wanted them to focus as well to pay attention to psychological violence, where it's a common consequence of violence, and as well to focus at economic violence. And finally, we wish to, for healthcare providers inside the one clinic, the rules to be clarified for them. And will make it easy for women where to go and to whom to talk rather than just only keep repeating her story to each healthcare provider in the clinic. I'd like to thank you very much for
heard about barriers to seeking care for violence against women from the West Bank. And now our next presentation will actually focus on a similar topic with work from having done interviews in the Gaza Strip. So our next presentation is actually on women's perceptions of intimate partner violence, and again, barriers to help seeking in the Gaza Strip, and it's being presented by Dr. Meghan Fitzgerald. So Dr. Fitzgerald is a mixed methods researcher with international experience in issues related to women's health and gender-based violence. She holds a PhD in public health from Oregon State University, where she focused on the impact of the political situation on IPV and access to services in Palestine. She also has several years of experience in public health program administration and evaluation, and she's currently a senior researcher with the US Overseas Cooperative Development Council. So we'd like to welcome Dr. Fitzgerald, and I think it'll be an interesting conversation to have to look at some of the similarities or differences across the two studies between the West Bank and the Gaza Strip after we hear Dr. Fitzgerald.
My name is Meghan Fitzgerald, and I will be presenting to you today about a study entitled Women's Perceptions of Intimate Partner Violence and Barriers to Help Seeking in the Gaza Strip. This study was conducted by myself, in addition to 2 co-authors. All of us are affiliates of Oregon State University. The study sought to understand women's experiences and perceptions of IPV, as well as service provided for victims of IPV in the Gaza Strip, and how they impact perhaps the decision to seek help. This research, particularly the interview instrument and analysis, was informed by the model of help seeking and change, as you see pictured here, which was developed in 2005 by Lang et al. This model describes influencing factors and temporal relationships between the elements of the decision-making process for seeking help. We partnered with women's organizations across the 5 governorates of Gaza and used convenient sampling to recruit 28 women at each site according to the inclusion criteria. Of those 28 women who were recruited, 25 completed interviews were used in our data analysis. We wanted to be sure that women had lived in Gaza for at least the last 10 years at the time of the study, which was 2017, to be sure that they had experienced the effects of the Israeli blockade, as well as increased aggressions towards Gaza from 2008 onward. I conducted in-depth interviews in the field with the assistance of a local translator. Interviews were audio recorded with participants' verbal consent, then transcribed into Arabic by field staff, and then later translated into English by the same staff. Transcripts were coded by two authors using an inductive approach or open coding approach in an iterative process. Coders pre-coded a few transcripts first on their own, then met to discuss and agree upon a list of codes, which were then applied to all the transcripts. Codes were analyzed for themes as well as relationships to each other. Our findings revealed three main themes or reasons why women did not seek help for IPV. The first theme was that women viewed help seeking as a betrayal of family reputation and community values, as well as potentially jeopardizing their status as women in society, which relied upon their acting in accordance with what society views as a good wife or a good mother. Many of these women mentioned fearing the social stigma that's associated with IPV, as well as the social consequences of such a transgression as seeking help, which included gossip, perhaps the loss of status or respect in society, retaliation from husband or other family members potentially. Another common theme was the cultural value that's placed on family in Gaza as the center around which everything else revolves. The belief that family matters are private and the family reputation and honor must be preserved, oftentimes even at the cost of one's own safety. One quote from a participant's account of IPV illustrates this point pretty clearly. She said, "Women don't seek help because of their children, the community traditions and habits. In our society, it's shameful to go and complain about her husband." The second theme illustrated how some women distrusted services that were in place for women. This included women's organizations, women's centers, centers for family and children. They worried mainly about staff gossiping about their situations to others in the community. And some women relayed stories of experiencing sexual harassment by male staff at these organizations. Others worried that seeking help for IPV might increase the violence and hardship experienced by women. They expressed uncertainty of the efficacy of services and actually resolving the IPV in the first place. And some stated the need for these services to actually target both men and women in a gender transformative approach. It is worth noting that the authors know of at least one women's organization in Gaza at the time of the study that was targeting men as well as women and involving men in their programming on gender-based violence and women's rights. So there may have been other organizations that were also taking this approach. The third theme revealed a tolerance or acceptance of IPV. Women mentioned viewing their situation of IPV as well as the situation in general of hardship in Gaza as one's fate or God's will, their destiny. They spoke about the normalization of violence in society due to the overarching political violence. It becomes normal, and thus the women expressed that there was more acceptance and tolerance of it because it was seen as a normal part of life in Gaza. And then further, and importantly, some women actually expressed forgiveness of their husband's violence because they interpreted it as a symptom of a larger political situation. For example, one woman said, "I forgive him because I understand it's a result of the hard living conditions that we are experiencing. I feel shy to seek help because I love him and I don't want him to be humiliated." This was the first qualitative study we know of that illustrates how women's decision to seek help for IPV may be influenced not only by socio-cultural factors, but more importantly, by the larger political context. For example, the participants exemplified acceptance of IPV as a symptom of the political situation and the resulting economic stress. The study also contributes to and expands upon the model of help seeking and change, as well as filling a stated need for qualitative research on IPV help seeking. Some limitations include response bias, as participants may have responded in a way that they perceive pleasing to the interviewer. I myself was the only interviewer, which could introduce intra-observer bias. And further, I was an outsider to the community, which of course may have impacted the way women in that community responded to the questions that I was posing. And finally, future data really needs to include men and service providers' input, as well as the women's. Based on our findings, we concluded that the socio-cultural view of help seeking as a transgression of community values and gender roles, as well as negative perceptions of services, were serving as barriers to women seeking help in the decision-making process of help seeking. Further, when women are faced with such socio-cultural barriers, which are exacerbated, of course, as we know, by a context of political violence, they have to resort to tolerance or acceptance of their IPV in order to cope psychologically. This is bolstered by a perceived lack of viable options for resolving the IPV because the women understand it as a symptom of the political situation, and thus the IPV would not be resolved completely unless the political situation was changed. While the themes and findings of our study mostly affirm and fit within the elements of the model of help seeking and change, our findings also suggest that women's appraisal of the root cause of IPV as either intrinsic to the perpetrator or extrinsic. In other words, if the IPV was due to the perpetrator's character alone, or if the IPV was a symptom of the larger political situation and stress. That appraisal may be a significant element to consider in women's decision-making processes, whether or not to seek help in similar contexts, as well as what type of help that they decide to seek, whether formal or informal, beyond problem recognition and definition alone. This appraisal is connected, of course, to the larger context of political power and structure, which is a very important upstream factor to consider in access to services. This context also directly affects the individual, interpersonal, and sociocultural influences on help seeking, as well as recognizing IPV as a problem in the first place, which can be hindered by the normalization of violence in a society suffering from political violence. As such, we recommended the additional elements that are outlined in red here for consideration in enhancing this model. Those elements would be the appraisal of root cause, as well as political power and structure. Interventions that target both women and men, providing education and awareness about IPV and women's rights, that also work to curb harmful gender norms, may increase access to help seeking as well as mitigate the occurrence of IPV. Although, again, as noted before, IPV will not be resolved without a change in the political violence experienced daily in Gaza. Service providers should consider perhaps relationship building activities with their communities that may increase trust as well as reduce stigma around IPV. And finally, many women also mentioned a fear of losing their source of income or their children through divorce. So policies that support women who decide to leave an abusive husband in these ways may also increase help seeking. We recommend future research that targets women from multiple countries in the Arab world, as well as Western countries where IPV is also a problem, to understand differences and similarities and barriers to help seeking across various geographical and political contexts, and thus informing models that are customized to various contexts. Further, studies should be conducted to compare the experiences of political violence and perpetration of IPV to understand the degree of association between those two factors. Service providers and men's perspectives must be studied alongside women's when having a dialogue about IPV, as a range of voices will provide naturally a more nuanced understanding of IPV and help seeking, thus informing interventions and policies aimed at improving women's access to effective services for IPV. And this concludes my presentation. Thank you so much.
Thank you so much, Meghan. Thank you for the presentation. I'd like to invite our participants to raise their hands or to contribute questions through the Q&A. But I just wanted to comment on sort of how sobering and striking these results are and how aligned the two studies that were just presented are in terms of both particularly the societal factors that are prohibiting or that are main barriers to seeking healthcare for IPV or violence against women more generally. Any questions here? And I think to me the other sort of striking feature is that it seems from the data from the West Bank is that it's largely the socio-cultural factors. The normalization was very much attributed to the fact that this has been going on for generations, whereas in Gaza it's very clearly pointing towards the political oppression, the political violence as being a root cause. And I don't know whether this was probed or not in the West Bank context, but this very clearly appears in the Gaza context. I don't know if you'd like to make any comments, Meghan. There's a question on the fact that there is a clear course of action or care pathway for physicians who encounter. So is there a clear course of action or care pathway for physicians who encounter a clear or suspected case of violence? And has there been any progress on this in Palestine more generally? I'm not sure. I think Amira is not here yet, but maybe Meghan can comment on this, but also on any reflections you may have on the findings from your study as compared to those of Amira's.
Thank you very much, Hala. Yes, I think that as I was listening to Amira's presentation, it was just validating kind of very similarly what I had found. And also to note that my study was conducted a few years earlier before hers. Mine was conducted, or data was collected in 2017. But many of the, as you explained, societal and individual factors affecting a woman's decision to seek help were very, very similar. Particularly, the normalization of violence. This is something that we know is passed down through generations. And hence why I think it's so important to look at the larger political context in which, this violence is occurring, because we cannot, with my public health background, we look at the social ecological model, from the policy, political level, all the way down to the individual. And so violence, it does trickle down from the political level to the familial, to the individual. And those patterns are become normalized and are learned. And we know from various studies on domestic violence, not just in the Middle East, all over the world, that have been done that show sons who see a father abuse his mother is much more likely, significantly more likely, to grow up to become an abuser of his own spouse, and a daughter who sees the same thing is much more likely to grow up to become a victim of husband's violence. So it's very important to understand each level of that and how that violence carries throughout. And so, when I was thinking about what I wanted to study, in Gaza, and I had some connections there, met with people there and stakeholders several times before, designing the final study and traveling there to conduct interviews. It became very, very apparent that, the political situation absolutely had so much to do with the perpetration of violence, interpersonally, the stress of the situation, the economic situation, which is a direct result of the political Israeli blockade. So it felt very important to me because I hadn't seen a lot of research out there that was looking at that level, right? Other than just, of course, the socio-cultural context, which they are connected. There are sociocultural factors that do influence, of course, a woman's decision to seek help, but they are connected and exacerbated by that larger political situation. So to answer the question, is there a clear course of action or pathway for physicians? I have to say I was not working with medical physicians in these interviews. I was mainly partnering with women's organizations and family centers, as well as mental health, the Gaza Community Mental Health Program, which does wonderful work with women as well as trauma experienced in Gaza. And for them, they have services actually set up for women who experience violence because they know that it's something that is very common. But the issue was that I think one of the Palestine, Central Bureau of Statistics studies that came out before my study showed that less than 1% of women were actually seeking these services in Gaza, even though they were available.
And I mean, there's clearly an issue of trust in both presentations. The issue of trust in the healthcare system to address the issue is clearly lacking. Both Amira said that women said that they didn't feel doctors would listen, that the community would know. Your presentation highlighted the trust issues also. And I'm just wondering sort of what can be done to sort of build trust in the healthcare system and its ability to address initially, to actually provide support for women, but then also to think about preventive interventions for violence against women. I may just also ask Hanan, would you like to speak up and ask your second question?
Yes, sure. So thank you for attempting to answer my first one. And I really would have liked to hear the answer from Amira, because I think this is an ongoing issue that we have. And, you talk about the lack of trust. Well, people don't trust because doctors are not empowered enough to do anything if they don't have clear pathways of care. So then the situation becomes, what is the point? They're not able to do anything. And that cycle continues. Well, anyway, on to my next question to Dr. Fitzgerald. So I think studying intimate partner violence in general is very, very sensitive, more so in the case of the very vulnerable situation that women are in Gaza. So I'm curious to just hear more about the the ethical considerations that you had to think about and the precautions that you had to take to make sure that these women were protected. Thank you.
Absolutely. Thank you so much for raising that point, Hanan. Yes, so in order to conduct this study, first of all, we had to, at Oregon State University, of course, go through our internal review board, so IRB, in order to pass, muster in terms of human subjects research, especially, as you said, with a topic so sensitive as intimate partner violence. There were several rounds of reconceptualizing, the ideas, like how, the structure of the study, how would we do this to best protect these women, especially as noted, in my study and the previous presentation, the fear of retaliation from a husband, for seeking help. Well, it doesn't end at just seeking help. I mean, there's also talking about it in general, right? And so IRB was, sought out and utilized, as well as the Helsinki Committee in Palestine, and getting sort of their input and approval of the study design, as well as I partnered very closely with the Gaza Community Mental Health Program, based in Gaza City, and worked with them and the women's centers that they work with very closely to sort of continually sort of reconceptualize that design and how can we do this in a way that is going to best protect them. So the idea that, so in recruiting these women, I went to these women's and family centers And it was a convenient sample, so it was where these women and families were already going anyways for various other services, not necessarily for IPV. So there was no change in their sort of routine or behavior that would make a husband suspicious. And then if they were interested, this is something, the recruitment happened at the Women's Center, and then if they were interested, then we decided on a day at a time that I would be there. They would come back to the center, and then the interviews took place in a confidential room that was provided at the center with the women.
And then was the consent also verbal? Because you mentioned the recruitment was verbal. Was the consenting also verbal?
Absolutely, yes. Yes, the consenting was verbal. It took place at the center. So the women were read a description of the study, a summary, and then if they were interested, they were asked to come back at a certain date and time where the interview would take place if they consented. And then we met one-on-one in the interview room. And then at that point, the women were reread a description of the study, of course, in the presence of a translator. And then they were asked if they consented to that and consented to the audio recording, so only for the fact that the interviews could be transcribed and coded. Their names were changed to name the files of the transcriptions so that these women's names were never used, their actual names, that is, and as well as connecting them and giving them resources and contact information for the Gaza Community Mental Health Center, so that if they felt re-traumatized by, reliving perhaps some of their experiences through the interviews or just talking about the topic in general, they had that resource to connect with, to sort of help alleviate anything that may have surfaced from the interview.
And sorry, final question. So just out of
curiosity,
just because I'm really interested in the methodology around researching vulnerable populations. So because you consented verbally, were you required to have a witness, or was the translator meant to be the witness?
The translator served as the witness, yes.
Thank you.
You're welcome, of course.
Thank you, Hanan, for these questions. Thank you, Meghan, for the answers. I was just wondering if anyone else had any questions before we moved on to the next presentation. I think the sort of what this session really makes us think about is what parts of the system are failing really to provide support to build this trust that women could have in the healthcare system. How can the healthcare system be supported to have these protocols, as you mentioned, Hanan, that are clear and that they can follow, and that have potentially, if needed, the legal pathways for referral, and that the consequences for women socially are not detrimental for their because both presentations showed that women really feared the social consequences of reporting and of actually seeking care for IPV. So if we don't have any, Huda, please, Dr. Izzy.
Sorry, I tried to write it in the chat and I didn't succeed. My question to both presenters is that you are both going to women and trying to understand how women view their health-seeking behavior, their own dealing with domestic violence. It seems to me that that it is hard for women living in this societal context to be the ones to take this step to go to the physician or to go there. And you mentioned, at least in the first study, that there was NGOs that were giving legal and social help to these women. And I wonder how much these NGOs can advance the services by going to the level of advocacy and policy and changing values, and taking on the fight together with some of these women. I wonder if these NGOs could bring physicians, just like giving social and legal services, they can also give health services, but to bring physicians that they have trained and who could talk to these women, and then the women can begin to understand how they can communicate or what physicians can do to them, but physicians who understand. physicians who have the time. So it's a very complicated problem, and I think NGOs can play a big role in supporting women to solve these problems and to have voice. I mean, they have to work with women also to have voice. I was wondering whether you had anything to say, Megan, on this.
Yeah, sure.
Did you work with NGOs? I wasn't sure that you worked through NGOs yourself.
I worked with local grassroots organizations in Gaza. So they were not international at all, or technically NGOs. And well, one thing I wanted to comment on in terms of, I didn't work with physicians, as I said before, that was, you know, Amira's presentation, but I know that one thing many women that I did interview spoke about, as well as the women who were the directors of these women's centers and organizations that I recruited from, they noted that, you know, it's difficult even for a woman to seek help from a physician, because oftentimes in Gaza, at least, I'm not sure about the West Bank, but the permission of the husband or the father in the family is required in order to go see a doctor. So, you know, imagine, you know, you're trying to seek help for something at least related to intimate partner violence from your husband. How, you know, how are you going to get his permission to go? So they, you know, sometimes women could think of ways to work around that, or they could make up other reasons, but it's very, very difficult, and it's very interwoven and interconnected with, again, sort of the political situation, the social and the cultural. But you know, I did want to say, you know, I mean, these local organizations that I worked with, they are doing a lot of work, a lot of good work within the bounds that they you know, the challenges they face with infrastructure, you know, lack of funding, you know, lack of mobility, and all of this, you know, so they're doing wonderful things. Some of them, I think I noted in the presentation, are actually providing interventions and programming that recruits men in the community. And again, that's not all of them across the board. And I think perhaps more of that would be really valuable in sort of the targeting at least the gender aspect of it, the societal, you know, gender roles and gender-based violence, you know, views in general. But some of them were recruiting male ambassadors, they called them, who would be trained in issues of gender-based violence and then would go out and be ambassadors in the community for these women. And so that is an example of, you know, how you transform gender norms and violence norms at the community level. And I thought that was really wonderful. But again, they're working with just significant barriers, both, you know, structurally and socially and societally. But, you know, within that, they you know, they could connect women to legal advocates if the women wanted to divorce their husband and wanted to leave. But again, oftentimes many women never made it to that point, because even though the service was available and they could technically divorce their husband, many of them would choose not to go that route, because if they divorced their husband, they might be, you know, they most likely don't have a job. You know, I think 92% of the women I interviewed were not employed, which is not surprising, because you know, especially Gaza has an unemployment rate of about 50% or so in general, men and women. And so they would be left without a job. Oftentimes they, you know, their family might disown them if they left their husband. And then they spoke about policies in Gaza, at least, where if they divorce the husband, the children at a certain age must go to the husband. Right. And so they were like, well, I don't want to leave my children with this abusive person, you know, and I don't want to lose my children. So there's many, many layers to this. But there is work being done and progressive work being done, you know, by these local organizations.
Yeah. And clearly, you know, there are different levels at which these issues will need to be addressed, and the systematic sort of political violence that is experienced by society at large in Gaza is part of the problem, and clearly there needs to be larger political systemic solutions to some of these issues. But along the way, surely there are levels at which interventions can be implemented, as you were saying, Meghan. Thank you so much for this extremely interesting discussion. We're going to move on to the next presentation, which focuses on the ethical, legal, and socio-cultural challenges of genomic research in a developing country, the King Hussein Cancer Center experience, presented by Dr. Amal Al-Omari. So Dr. Al-Omari is the Chief Scientific Officer at the King Hussein Cancer Center. She holds a PhD in clinical pharmaceutical sciences from the University of Iowa and has more than 20 years experience in pharmaceutical research and development, academia, oncology research, and research administration. And her research mainly focuses on the epidemiology of NCDs, in particular on oncological malignancies in Middle Eastern populations, especially in Jordan, and with a focus on underprivileged and displaced populations. It gives me great pleasure to hear Dr. Al-Omari's presentation.
Hello, dear all. My name is Amal Al-Omari. I'm the Chief Scientific Officer at King Hussein Cancer Center in Amman, Jordan. First, I'd like to thank the organizers of this conference for giving me the opportunity to present to you part of our work on genomic testing for hereditary breast cancer, which is more related to ethical, legal, and socio-cultural aspects. So my talk today is ethical, legal, and socio-cultural challenges of genomic research in a developing country. The King Hussein Cancer Center experience of BRCA1/2 mutation testing among a sample of breast cancer women of a mixed Jordanian-Palestinian origin. I have no conflict of interest to disclose with regards to this study, and funding was provided by a competitive grant from the King Hussein Cancer Center in the Anderson Cancer Center Sister Institution Network Fund. First, just a bit of background about the study. So breast cancer is the most common cancer and the leading cause of cancer-related deaths among women worldwide. Unfortunately, according to the WHO, around 70% of deaths from cancer occur in low and middle income countries, and this is most probably due to late stage presentation and lack of access to diagnosis and treatment. In Jordan, median age at the presentation for breast cancer is 50 years, which is 10 years younger than Western societies. And this might reflect a high prevalence of hereditary breast cancer in our population. Additionally, more than a third of patients present with locally advanced or metastatic disease, which highlights the importance of early detection programs. Therefore, identifying higher risk groups of patients to which preventive and early detection efforts can be directed is extremely important. Now, data related to hereditary breast cancer among the Arab countries is very scarce, and prior to this study, none were reported from Jordan. So the objectives of this study were, first, to evaluate, and for the first time, the contribution of germline mutations in BRCA1 and 2 genes to breast cancer treated at King Hussein Cancer Center. Of course, BRCA1 and 2 genes are the two most important autosomal dominant breast cancer susceptibility genes that account for the majority of breast and ovarian cancer in high-risk families. And second, to present our experience in dealing with this delicate cultural issue in a tribal-based country with a blended Palestinian-Jordanian family origin, where familial ancestry still plays a major role in social relations and marriage rituals, all in the absence of formal genetic counseling services similar to what exists in Western countries. I'm not going to go into the clinical details of the study, just to focus more on the ethical, legal, and social challenges. So for this, 30-minute interviews with the patients were scheduled initially for the introduction of the study and the proper consent, and then again for the disclosure of genetic test results. So we'll summarize the challenges encountered, and we'll present examples from real patients' cases highlighting the ethical dilemmas that were raised. For the results, 100 patients were enrolled into the study. 6 were residing in the West Bank, so they were coming specifically to KHCC for treatment. Many others, actually around 70% of our population descended from Palestinian origin, and this was not surprising to us, knowing the blended nature of the Jordanian families. Median age of participants was 40 years, range 22 to 75. 51% were below the age of 40. 89% of patients had positive first and or second degree family history of breast and or ovarian cancers. 20 patients had deleterious and 7 suspected deleterious mutations in BRCA1 or BRCA2 genes. So these mutations, deleterious and suspected deleterious mutations, means that they are pathogenic mutations or disease-causing mutations. 7 other variants of uncertain significance were also detected. Importantly, all patients with BRCA1 or 2 mutations had significant family history of breast and or ovarian cancer. Now, before going into the ethical dilemmas, I need to give you a brief on how this study went with our IRB or our Research Ethics Committee, considering that it was the first study looking into such a sensitive cultural matter. So upon initial submission to the IRB, we did not have the intention to share the results of genetic testing with the patients. It was totally a scientific endeavor to us as investigators, with no clinical implications for the patients. However, after further communication with experts and colleagues abroad and discussion with the IRB, the direction changed. Since really the results of genetic testing have clinical implications for the patients and their families, so it wouldn't be ethical not to share the results with them. So we proceeded to modifying the IRB application and consent form. However, we kept the disclosure of the test result only to the patient if she chose to know the test result. And this was also for further protection of her privacy and confidentiality. We were also providing the IRB with interim reports of the study whenever we recruited 10 patients. So after recruitment of our first 10 patients, it was very noticeable that all patients who agreed to participate wanted to know their test result. More than worried about the risk of their cancer recurrence, they were actually more concerned about the risk of breast cancer for their children and their daughters in particular. We also felt that it was very important to involve the treating physician with the test result, since patients who test positive will need a close follow-up and application of risk management strategies that may involve changing their treatment plan, even risk reduction surgeries like mastectomies or bilateral oophorectomies, and it will be very difficult to do any of those without knowledge of the treating physician. So another modification was submitted to the IRB where we gave the patient the choice in the consent form of whether she'd like her treating physician to know the test result and to place the test result in her medical chart in order to justify any further clinical management plan based on the results. Now on to the ethical dilemmas. First, ensuring confidentiality and privacy in a tribal-based, closely related culture. And here I'm going to share the experience we had with one of our patients, BRCA034. So this patient was the 4th sister diagnosed with breast cancer, added to 3 other sisters with the disease. She was very cautious with regards to privacy and confidentiality, knowing that her family was plagued with cancer. And during the consenting process, we explained to her that she had the choice of whether she wanted her treating physician to know the test result and to place the test result in her medical chart. And despite clearly explaining to her that this may affect her clinical management if she was found to have BRCA mutations, the patient still did not want the test result to be disclosed to the treating physician, nor to be included in the medical chart. And the patient explained in her own words, الناس في مجتمعنا بسطة وكتير بيهتموا بهاي المواضيع وانت عارفة يا دكتورة احنا عنا بنات. So she was actually more concerned about labeling her family with breast cancer and stigmatizing her daughters with breast cancer, which might actually affect marriage proposals later on based on how the culture goes on, rather than clinical management of her own cancer. So obviously, social labeling and stigmatization was a great concern for our patients, despite our major efforts to protect their privacy and confidentiality. Also, this case raises the concern of autonomy versus beneficence. It is with no doubt that the patient has the right to refuse or choose her treatment, But then acting in beneficence means that the physician should do what's in the best interest of the patient. And here, these two principles are obviously conflicting. Fear of false assurance, and this relates to patients who test negative for the genetic mutation. So when we disclose the negative test result to those patients, we explain to them that their first-degree relatives, in particular female siblings and children, are still at a more increased risk of breast cancer than the general population. Therefore, they should be vigilant in following the guidelines for screening and early detection of breast cancer. However, the patient's understanding of the negative result when explained to them varied. One of the patients, for example, kept asking, "What do you mean? I just need to know whether my daughter will inherit the disease or not." Another patient who was based on her choice, accompanied by her mother-in-law in the visit, stated, "Great, I'm genetically clean. Alhamdulillah, جيناتي نظيفة." That's what she said in her own words. Scope of physician-patient confidentiality when relatives are at an increased risk of cancer. So we have to realize that it's a family affair. It's not only about the patient when she tests positive for a germline mutation, because this means that other family members are at increased risk of cancer. And though our IRB raised concerns with regards to sharing information with at-risk relatives, most of our patients who tested positive for deleterious or suspected deleterious mutations, actually except for 3, had no issues to share results with their at-risk relatives. Also, preserving other family members' confidentiality when documenting family history was discussed with the patients during the consenting process. Fear of social discrimination and stigmatization, as I just explained earlier. So during the consenting of the patients, we explained to them potential social risk associated with their participation, including potential insurance, employment, and social discrimination, especially if they test positive for a genetic mutation. And that's, of course, despite all the efforts that we do to protect their privacy and confidentiality. So we know that most insurance agencies don't cover risk reduction procedures, including mastectomies and oophorectomies. Also, what if the patients or their relatives were discriminated against in a job opportunity just because of their cancer family history? We know that there are data protection regulations in many countries in the world. For example, in Europe, the GDPR, in the US, HIPAA, many other countries in the world, Brazil, Australia, Japan, Thailand, India, China, and Canada, but none exist in this part of the world. So this study highlighted a legal void in local genetic testing and data protection regulations. Now, only 3 patients declined to participate in the study, and I thought it is interesting to share their stories. The first patient who refused to join the study initially claimed that she was afraid of the needle stick, then expressed concern that her husband wouldn't agree, though she stated that she was almost sure that her cancer was hereditary because her mother also had breast cancer, but she wasn't willing to undergo testing. So here, male dominance or the male patriarchy actually precluded this patient from joining the study. The second patient was totally confused with the idea of genetic testing. She didn't know what she should do with the test result. Whether she should keep it to herself if she tested positive, share it with her husband or family members. She was also very anxious when we asked her whether we can keep her sample for future research. She kept asking repeatedly, "Why do you need to keep my sample? What are you going to do with my sample?" Despite that, we explained multiple times to her that we are not going to use her sample. We are not allowed. We cannot use her sample in future research without her prior approval, but still she was very reluctant. Eventually, she agreed to join the study. She signed the consent form, but minutes later, after she reached the lab for the blood draw, she declined again. The third patient was even more interesting because she was a physician with a strong family history. Her mother, sister, aunt, and cousin all had breast cancer. However, she still refused to do the genetic testing, stating that ignorance in these matters is better. الجهل بهاي المواضيع أحسن. That's what she said in her own words. And then explained that she was too scared to know the test result. Now, of note, this patient was not married. She did not have any kids. And this re-emphasized to us the note that we observed earlier, that the patients were more interested to the test because they were concerned about cancer risk to their offsprings rather than their own health or their own cancer recurrence. Now, conclusions. Based on the results of this study, BRCA1/2 mutations are not uncommon in our population of mixed Jordanians and Palestinians and are likely to contribute to the pathogenesis of familial breast cancer in this population. Knowledge of BRCA1/2 mutation status has significant clinical implications for the management and the prevention of breast cancer. Therefore, full BRCA1/2 screening should be offered to patients with characteristic family history. In the setting of limited resources like ours, a subset of patients with higher risk features can be an option. Running a culturally sensitive genetic research in a developing country with limited resources is a challenging exercise and highlights the urgent need for guiding regulations. Future recommendations for establishing a clinical cancer genetics program are also envisioned, where unaffected family members should also benefit from early screening and take appropriate measures to reduce the risk of breast cancer. Thank you, and I'll be glad to answer your questions.
Thank you so much, Dr. Al-Omari, for a very interesting presentation, for highlighting some of the cultural factors that we need to take into consideration as these screening programs may become more and more available in our contexts. I'd like to open up the floor for questions. So there's a question around whether women with genetic BRCA1 or 2 do mastectomy as a prevention. I heard Dr. Al-Omari say that this wasn't covered by insurance in Jordan. Perhaps you want to comment on that?
Oh, yes, sure. So actually, how insurance works for our patients at King Hussein Cancer Center is that most of them are actually covered by national insurance. So they are covered by specific insurance for cancer from the Royal Court. And how that insurance works is that it covers any treatment related to cancer. So when we started the study, of course, BRCA testing wasn't in our guidelines. So testing high-risk women for genetic predisposition to breast cancer wasn't still part of our clinical practice guidelines. But based on the results of this study, we then added genetic testing for high-risk women to our clinical practice guidelines. So women who test positive for a mutation in BRCA1 or 2 then are eligible for risk reduction surgeries, including mastectomies and oophorectomies. So now, yes, we can do mastectomies. And of course, these are breast cancer patients, so some of them probably already underwent a mastectomy. Or if they underwent lumpectomy and now they want to proceed to mastectomy or for a bilateral mastectomy, then they can do that as part of their cancer treatment, which is covered by the national insurance. And same applies also to oophorectomy. So now we can do it at King Hussein Cancer Center. And actually, many of our patients included in that study did that, who tested positive, I mean, of course, for the mutation.
I was just wondering, is that the same for people whose status is Palestine refugee, or would their eligibility for preventive surgery change?
So that's different because the National Cancer Insurance, the Royal Court Insurance, covers only Jordanians. So how we treat Palestinian refugees here at King Hussein Cancer Center, either they are going to be covered from their home country, of course, from the Palestinian Authority funds, or from the Goodwill Funds. So we have like what we call Sanadiq al-Khair, the Goodwill Funds. Sometimes we use those funds to treat Palestinian cancer patients here at King Hussein Cancer Center.
Thank you.
Course,
Hanan, would you like to ask? Sorry, go ahead.
That wouldn't, of course, cover risk reduction. That would be direct, because that would be very limited fund, and it will be directed to treating their cancer specifically.
Right, right. Hanan
that is
had
a challenge, of course.
Sorry, Hanan Abdirahim, would you like to ask a question around genetic counseling?
I do. I actually have two questions for Dr. Al-Omari, and I want to say thank you very much for this presentation. I think genetic sequencing and genomic sequencing is becoming more common in our region and has really important implications for for medical care, but also for public health. So my question for you, my first question is on the availability and the qualifications of genetic counselors, because I know that we have a problem in general in the region with certified genetic counselors. So can you tell us what the situation is like at KHCC? And my second was, in thinking about other studies in the region that have started to look at acceptance of genetic testing and so on, have you considered looking at religiosity or fatalism and finding instruments to measure those as determinants of readiness to test? Because a lot of times what people will say is, what is the point of knowing? It's preordained, there's nothing I can do to change it, or they feel like it's a challenge to to the will of God. So just those two questions.
So for the first question, the qualifications of the genetic counselors, when we started this study, we didn't really have any formal genetic counseling program here at King Hussein Cancer Center. So the counseling was done basically by the treating physician for the patient. Somewhat during the consenting process for the study, and then more in detail if the patient tested positive for the genetic mutation. But after we had this study and we had those results, which showed like a significant prevalence of these mutations in our population, one of our staff actually went for training at Leeds University Hospital in the UK, and she came back here and we started implementing actually what I said about a formal clinical cancer genetics program. Now it's actually underway at King Hussein Cancer Center. So we do it as part of our clinical care to patients. We counsel them for the genetic risk for breast cancer, especially if they have a significant family history, and they are offered the genetic testing for BRCA1 and 2 in addition to other genes now. So now we do a panel. Instead of doing just the BRCA1 and 2, we do a panel for hereditary breast and ovarian cancer. And if they accept to do the test, it's done as part of their cancer care. So it's not being done as research now. It's part of their care. And actually, I did not get the second question. So,
sorry, so I can repeat my second question, but just to underline the point that you just made, I think it's very important from an ethical and a quality of care standpoint that if we're going to be asking people whether they want to be tested and offering that and extending that service to them and to family members, I think it's very important to make sure that we first have a sufficient cadre of qualified genetic counselors. Especially as your presentation pointed out, sometimes the information is very nuanced and people really don't understand what it means. And it's all about how you communicate that to them. So thank you for responding to that point. My second question was about whether you have considered perhaps in future research based on other studies in the region looking at religiosity or fatalism as a determinant of accepting to be tested, and whether you've thought about how you would measure that.
Well, actually, that study, no, we haven't, but thank you for bringing that up, because I think it would be very much relevant to our population, because I did a significant part of the interviews with the patients in the study, and I can tell you based on my experience talking with the patients that this plays a big role in maybe the patient's decision on whether to do the result or not. So maybe something to be taken in consideration for future studies.
Thank you very much.
Thank you. Do we have another 2-3 minutes for any other pending questions? There was a question around mastectomy as prevention from breast cancer, but my understanding was that you were saying that it is now being covered potentially for Jordanians through the center, but not necessarily for Palestine refugees, correct?
Yes, that's true for breast cancer patients, but like if I'm not sure whether the question relates to breast cancer patients or maybe like one of the relatives tested positive for the mutation and she's not a breast cancer patient yet, whether she would go for a preventative mastectomy. Is that the question?
It might be. Would you like to answer that as well, just in case?
I don't think that we had that experience yet here, and I'm not sure. Maybe that's actually worthy of a study on its own. And I think it's one study. Maybe I think Rana is with us. Rana is on the team for another study looking on asking patients, right? Rana, can you comment? Are you with us? There's another study ongoing now. It's a qualitative type of a qualitative, quantitative, mixed method study, looking, asking patients who underwent the testing on what they did with the result and how they shared it with their family members. So maybe this study can also give us insights on how family members reacted to the test result, whether they did testing, whether they decided on risk reduction measures based on the result. But from this study, the results of this study, the one that I presented, we don't have answer yet, but ongoing studies might provide us more insights into this question. It would be really interesting to see whether, like, a healthy female decided to do a risk reduction mastectomy just due to her risk for cancer. That would be interesting to know.
Thank you very much. Yes, and taking into consideration, as you said, the cultural and ethical considerations of having these kinds of technologies currently available as a service in such populations, and to Hanan's point as well, the need really for the genetic counseling to be adapted to the cultural context, and really for women to understand what this means in terms of their risk and their options and the risks for their families. Thank you so much for this extremely interesting session. I'd like to now hand over to Dr. Hanan Abderrahim, who's going to be moderating the next session on children and adolescents.